Up next, Noel Bairey-Merz is joined by Dr. David Dixon, a PharmD at Virginia Commonwealth University School of Pharmacy in Richmond, Virginia. They cover nuts and bolts of the new anti-obesity drugs and which one for whom, pharmacology, drug-drug interactions, and efficacy.
Welcome, Dave.
Thank you.
Cardiologists in general, remembering the fen-phen situation, are not probably prescribing obesity drugs. So tell us why we might consider prescribing.
Sure. So the anti-obesity agents that we currently have available might be a way of helping patients lose some initial weight so that maybe they can become more physically active. And so that could potentially be one way these agents could be used. And obviously increasing physical activity is good for heart health, particularly for patients that have finished cardiac rehab maybe, and they've made some lifestyle modifications, but they've really not achieved their personal weight loss goal. So it would be reasonable to use these agents in those patients.
And you would do it even after they've already incorporated some change. That's
Absolutely.
Not inappropriate.
Absolutely. And if you look at the clinical trials, all of the participants in the studies did receive fairly intensive lifestyle modification, lifestyle education, and so that has to be a part of the treatment. These drugs are simply adjunct to that.
And they're indicated for a BMI of 40, 35, 30, 25. Where should we be thinking about this?
The recommendations currently would say that if you have a patient that has a BMI of 30 or greater, definitely would be worth considering, particularly for those patients that have an elevated body mass index and have at least one additional risk factor, such as hypertension or diabetes or dyslipidemia.
And so specifically, given, again, the risks of prior drug formulations, those aren't contraindications. Our cardiac patients could take these medications.
That's an interesting question, and I would say that for the naltrexone and bupropion product, as well as the phentermine to pyramate combination, that blood pressure should closely be monitored, as you can see an increase in blood pressure, particularly with the phentermine and bupropion components, because those agents do have a stimulatory effect, and clearly monitoring blood pressure and heart rate would be critical.
So let's then go to sort of prior safety, and let's talk a bit about fen-phen, because that's kind of what's going to be in most cardiologists, and why this new stuff we should be thinking about it.
The fen-phen product, which was removed from the market in 1997 due to causing valvulopathies, and really it was the pulmonary hypertension that really caused some deaths and was concerning. So with the lorcaserin product, one key difference is that that agent targets the serotonin 2B receptor, which is found only or mostly in the hypothalamus, whereas the fenfluramine product targeted 5-HT2C, which of course was in the valves. And so the product, the lorcaserin product that is highly selective for the 2B receptor, at least appears, based on the data available, to be safe. If you look at the incidence of valvulopathies in the studies that have been completed, there has been no statistically significant difference between the placebo group and those patients receiving lorcaserin. With that said, there is a large cardiovascular trial underway with lorcaserin, the Camella-TIMI study. And so in 2018, I would say we would feel much more comfortable once we see that data to prescribe that particular agent.
Although it is available now. It is approved for weight loss.
Correct.
And presumably the big clinical trial not only is to show safety, but maybe efficacy for reducing cardiovascular disease?
That is the hope.
New products are available. They are FDA approved. They are found to be effective for weight loss. What could we expect to see? 5 pounds, 10 pounds, 20 pounds, percent?
If you look at the products, the phentermine and topiramate product, that combination product at the highest dose actually is considered to be the most efficacious. And so you're really looking at a large majority, over half of the patients that take that higher dose will achieve at least a 5% weight loss. The naltrexone and bupropion product would sort of be considered the next best in terms of weight loss. 5%, 10%, it's really about setting the goal with the patient and understanding what they're trying to do. If a patient comes into your office and says, I would love to lose 100 pounds and that's my goal, these drugs are not going to do that. They may be adjuncts to get patients started, but really it's going to be about them taking responsibility and making some permanent lifestyle changes to maintain weight loss and achieve such a high goal.
I'm reminded of that New Yorker cartoon where the physician is handing the patient this massively large tablet of aspirin, and he tells the patient to take it for a walk every day and then swallow it. So these are adjunctive. Let's talk a bit more about side effects, because what I think we're probably going to see, because these are newer either reformulations or truly new serotonin drugs, I think as a cardiologist, we're going to see them prescribed by other people, and we're going to be sort of the bystanders receiving perhaps the blood pressure control is not as well done or some other side effect that we don't know about it. So tell us about that.
You look at these products, I would say lorcaserin is fairly well tolerated. There are more patients that discontinue the medicine due to adverse effects compared to placebo.
Like what percent?
So for that, you're looking at close to about 10% of patients. Not bad. However, if you look at the naltrexone and bupropion product, you're really looking at a discontinuation rate of almost 1/4 of patients, and that's going to be due to side effects. And so, again, tolerability is key. Liraglutide, which has been reformulated at a higher dose compared to the liraglutide we use for diabetes. So the weight loss product, liraglutide, nausea is a huge side effect, and about 40% of patients will experience that. With that said, the nausea does improve within 2 to 4 weeks, and so it's really about coaching patients through that, because patients that can get past that initial couple of weeks, the data does show that tolerability of that agent improves dramatically. There are definitely some issues in terms of GI side effects with that product. Another concern with liraglutide is the potential risk for acute pancreatitis. And again, the black box warning as far as medullary thyroid cancers. So clearly there are some big things that you want to look at and make sure that the drugs are appropriate for these patients.
And one of the things, therefore, that we would see in our cardiology area, we're evaluating patients for chest pain, shortness of breath, and hypertension. Many cardiac patients have hypertension, so that's probably what we're going to notice. Would you rank order these in terms of which ones are going to be that stimulant and which have less of that?
So phentermine is a sympathetic mimetic amine, and so you're definitely going to get a stimulatory effect, increase in blood pressure and heart rate, and I would say that's the product I would watch closely. In addition to that, the bupropion and the bupropion naltrexone combination, again, can increase blood pressure. It is an antidepressant, but it does...
Like the other SSRIs sometimes can.
Yeah, and it has an effect on norepinephrine, so it inhibits the reuptake of norepinephrine, so you're going to get a little bit of increase in blood pressure and heart rate. So lorcaserin, not much of an effect on blood pressure. Maybe it'll actually go down a few points. And same thing with liraglutide. I think, generally speaking, from a blood pressure perspective, those would be the considerations. And I wouldn't start a patient on the bupropion or phentermine products that had highly uncontrolled blood pressure. Obviously, getting the blood pressure controlled first, and then considering the addition of those agents.
Yeah, well, and then we just struggle with it's out of control. But if they lose some weight, it's probably the end game is what we're after. Okay, great. Well, this has been very helpful. We reviewed why we would prescribe, that there are new formulations that may be safer than prior formulations, although the big trials are underway. We talked about side effects, particularly specific to the cardiovascular area, and that we should have you back in 2018 to talk about that big trial. Thank you.
That sounds great. Thank you.